2022 regular Board of Health meeting. We are conducting this meeting in hybrid fashion today. We're going to work out some of the bugs with the new system. So I am the only board member that's here today, but we do have Morgan, McMillan, and Landry on, so we do have a quorum. I don't have the spiel in front of me for the bylaws and all that, but we've heard it all before. So we'll go ahead and kick off the meeting. Time is 5:33. And then we always start out the meeting with public comments. I think we have a few people on the line who are going to provide comment.
So looking at the guests online, the only one that is here to make a public comment request is Ryan Scott. So Ryan, I'm going to allow you to unmute, and you have 3 minutes.
He's muted. He's still muted.
Ryan, you can unmute.
Hand is up.
Ryan, I see your hand. You should be able to unmute.
Sorry, that's me. My volume's working.
Okay. If he's not able to unmute, I gave him permission to.
Do we have, we don't have chat on this, do we?
But does he know how to unmute?
Could I look at his comments and at least try to read those off?
I just said he just wanted to talk.
Oh, okay.
Can we try calling from the call function?
Okay, Brian, you may have to log out of the meeting and log back in. We can try again.
Try that, Ryan, and we'll come back to you.
Yeah.
Morgan, do you have a question?
I think she was doing that to alert me that she's there.
Oh, okay.
Yeah. Okay.
You can hear us fine, right, Landry?
Yeah, I was just gonna say in the beginning I had my hand raised because I was unable to unmute. Now I can clear able to. So that might be Morgan's issue also.
Okay. I'll alert her in. Thanks, Landry. Okay. Brian, I have allowed your microphone. You're able to unmute. He has to unmute himself.
He was unmuted a second ago.
Yeah, he wasn't unmuted just a second ago.
He's on a computer.
I can't.
Oh, well, hand went down.
Yeah, I can't give you access to the meeting itself, Ryan, but I have enabled your microphone, so you should be able to do it yourself. It's all on him now.
Okay.
Yeah.
The only other option is to call in via the phone.
Mhm.
I don't know, Ryan, if you have a different device to access the Teams meeting on. I think this is our first meeting with Teams versus Zoom, right?
Yeah. But this room is more conducive to Teams, so
Right.
once we get going, it's fine.
Okay.
I can. If I give him access, he can control things and. No. Well, Mike, yeah, it's all on.
Okay, well, we can try another device, Ryan. I know that might not work. And if so, and we get you back with a voice, we will just go change the order of the agenda. But for right now, let's just move ahead with item 2, which is approval of the August 8th, 2022 regular meeting minutes. Morgan able to unmute?
This is Landry. I move to approve the August meeting minutes.
I suspect, Morgan, you are unable to unmute as well.
Yeah. All right, try now, Morgan.
Yes, I can
Okay, sorry.
unmute and you can see me.
Awesome,
Great.
awesome.
I was having the same problem as Ryan. I could not
Okay.
unmute or do my camera, so.
We can do, so we could try that with Ryan if you have to. Sorry.
Yep. Anyway, so I second the move to approve the minutes.
A motion and a second. All in favor? Aye.
Aye.
Okay. Let's see, we don't have anybody else. I don't recognize that EW name. Is that a staff person?
Yep.
Okay, all right. Give Ryan one more try here.
All right, Ryan should be able to unmute. I'm so sorry about that.
Fantastic. Looks like it's working now. So
Very
thank you.
good.
There you go.
Cool. Right, your 3 minutes starts now.
Great. Thanks. I just want to speak. I'm glad to see you're back in person now. I don't know if audience, or I'll say community members, are welcome there, but I'm sure you can clarify later. Just wanted a quick note just to continually impart on you folks. Obviously being in person's the best, so I'll do my best to make it there so I can meet you in person. Unfortunately, I found your the way that you enacted public policies all throughout COVID was an absolute train wreck. And I know you had COVID dollars to spend. You didn't do it very well. You never imparted a very balanced viewpoint. Each and every one of you just functioned essentially as pharma reps, just pushing exactly what the CDC said or otherwise without any level of critical thinking. Your vaccine verification program, what an abject mess. No wonder so many community members push back on that. Let's hope that's a brainchild that's long lost and forgotten, as with lockdowns and everything else that didn't work that you imposed on our community at large. So I think it's refreshing to see that there's a number of lawsuits going against the CDC currently. I think we'll continue to get more and more a clearer picture. As for the most recent round of boosters, the fact that there's no clinical trial on those is almost laughable from a position of, hey, everyone, go take this thing. It's rather miserable from a health perspective. I've done the exact opposite of every bit of health guidance that you've given out throughout this, and I couldn't be healthier and only had COVID once. So big whoop on that one, I guess. There's been a lack of policy transparency, policymaking transparency. As it relates to kids, you were entirely unable to effectively communicate their actual risk throughout. So kids abjectly affected. We see they have speech issues now. Otherwise, that was wholly imposed by yourselves. That's not good. Obviously, if you look at all-cause mortality, since no one ever there will ever acknowledge vaccine injury or otherwise, all-cause mortality in countries with amazing, fantastical vaccination rates are increasing. That would imply there's a rather failed product on the market. Anyways,
30
that'll
seconds.
come to light soon. So anyways, just continually trying to urge you to present a different perspective. Don't all be aligned. Don't all be going down the straight and narrow saying we've got to vaccinate this whole community. That is not the right step. And your guidance was so wholly off target that I think you really missed an opportunity. So I think you need to come back and try and work with the folks that are here in Boulder.
That's time.
Thanks.
Okay, thank you. All right, let's see. We are moving on to item 3 in the agenda, which is strategic planning.
Great, thank you so much, Greg. Lexi Nolan, Interim Director of Boulder County Public Health. Welcome to our first agenda item this evening, which is an early glimpse of the work ahead to develop a new strategic plan for Boulder County Public Health that'll range from 2023 to 27. Despite the amount of work that we have at the moment, generally the timing is good and presents an opportunity to strengthen our agency and refresh our approaches to supporting a healthy community. This work is being led by Kelly Hinch, our Director of Strategic Initiatives, who's been working to both get the work off the ground and to keep us on schedule, and also to ensure that we have the resources effectively to do the work. Kelly, let me turn it over to you.
Yeah, thanks, Lexi. Greg and Landry and Morgan, thanks so much for joining today.
Slide.
We're going to go to the next slide. Sorry about that. But before we jump into that, I want to take the opportunity to also introduce Elise Wallen. She's our new health planning and evaluation manager. And I remember when I was in that position, I also came to the board and was introduced. She plays a pivotal role inside of the strategic planning process. So I invited Elise just to pop in and say hello. Give me a second. I think we're going to give you some ability to pop in, Elise. Hold on a sec.
Thank you all. Can you hear me?
Yes.
Yep,
Yes.
you're good.
Hear and see.
Perfect. Thank you. Yeah. Good afternoon, everyone. It's wonderful to have an opportunity to meet you. Hopefully I'll have an opportunity to meet you all in person in the not too distant future. As Kelly shared, my name is Elise Wallen. I am the new Health Planning and Evaluation Program Manager. Prior to joining the BCPH team, I was at Jefferson County Public Health for the last 6 years, the last 4 of those years with their epidemiology and planning team. So I was able to support the department with a variety of strategic initiatives, everything from supporting our CHA-CHIP process to our strategic plan, performance management, data governance, quality improvement, program evaluation, accreditation. Got to wear lots of different hats. So I'm very excited to bring my skill set and abilities to the BCPH family, and I look forward to working with all of you.
Awesome. Thank you, Elise. Yeah, we're really excited. We've been without an HV manager for quite some time, so we were pretty excited to be able to bring Elise on board, especially with her background and experience. Thanks so much, Elise. So I'm going to jump into our slide deck here a bit. And as Lexi said, it's a little snapshot. It's a snapshot looking forward at our strategic plan, our next 5-year strategic plan, which really runs from 2023 through 2027. And so what I'm going to focus on in this presentation, this brief presentation, is really pulling out the framework, right, of this plan. And not doing a deep dive into some of the details for a couple of reasons. One is I don't think we're there yet. We want to have a lot of community and staff engagement in this process. But it'll give you a good idea of our thinking, of sort of the basics around our strategic plan, and some of the expectations I have for y'all once this presentation is over, is I should be able to really, maybe name some of the key points of the plan and have a little bit better understanding. And then you also have some opportunity to provide some, if you have any questions or whatnot. Next. So just a snapshot, we've been working on this plan for a few months now, frankly. Lexi and I have been engaging in lots of conversations, and we've been moving some pieces forward from really, frankly, as early as late last year, right? At this point, just to let you know, we have chosen mental and behavioral health, that's an MBH space, as our next public health improvement plan priority, right? And how we got to that was if you recall, last year around this time, maybe a little bit later in fall, the county with ARPA funding did a community engagement process, and where the community identified mental and behavioral health as a health priority for them. And so especially since we've been working on mental health at our current strategic plan, we said this is a great opportunity for us to move forward in that same space because it was tripped up by COVID, as you can imagine. We've also been working on what's called the community health profile. So it's really broad secondary data that focuses on a range of health indicators in our community. So it's a snapshot of health in our community as it currently stands, right? And I'll get to the importance of those pieces and what it means as we pull out priorities. And we've been having internal preliminary discussions on priorities for strategies to inform the framework, right? So we've been speaking with staff, speaking with community partners, with county partners and things like that. And we have contracted a consulting group called Omni, who has a ton of experience working in Boulder County. And they're going to be helping us lead the community health assessment process in the development of the public health priority, right? Public health improvement plan, sorry. Okay, next. Jordan.
Sorry, Kelly, can I jump in and ask you, did Omni do the last strategic plan for Boulder County Public Health? They did not, did they?
No, we did the last one. I wasn't here for the last one.
It was done in-house. Right, okay.
Yep, I wasn't here for that, Morgan, but we thought this time was sort of coming out of COVID and we have some staffing issues and things like that. So it would be good to have a consultant come in who is experienced, knows Boulder County to help lead that process this time.
Yeah, I have worked with them over the years. They do a good job.
Yep. So what about our current strategic plan? So just as a reminder, our current strategic plan runs from 2017 through into this year, 2022. Our priorities that we had originally set were mental health, stewardship, transparency, and sustainability, right? Health equity, and then later on we added climate action. And that was a space, I think, right before the pandemic hit, was we were looking at climate change. So that was a new priority that we put in place. So in these spaces, we had done some work before COVID hit here. We had some delays. We had some staff that were leading some processes that had some health issues and had to step out and come back in. So there's several delays, but we do have some accomplishments from that space. And then since maybe about a year or so, we've been re-engaging in that process, right? And for example, we have several youth mental health pilot programs running in our agency right now. And so what's next for this space is at the end of the year, our plans are to gather some of that data, because I think you've done a lot of work, especially in the health equity space, that was sort of unintentional, but a lot of great lessons learned to talk about with the community and how we're able to build that into a report and what are lessons learned. And basically, in particular, since we're looking at mental behavioral health as our next current community priority, is to build on those experiences and lessons that we're going to be pulled from this last planning process into the next one. Exactly. So just a quick, what is a strategic plan framework, right? So I basically wrote down, why are we using this framework? Because I want y'all to understand sort of a clear understanding of goals, a theory of change, and how we got there, right? I think some people will really get tripped up on this language, and we really want to make sure that people understand, what is the broader framework of how we're building this plan. And it helps us move in alignment with social determinants of health, root causes, the strengths of current program we have, and things like that. So just wanted to give you a little explanation of why we're talking about a framework first and foremost, and something that's a fully built out plan at this point. Next. So I'm going to jump into the framework right now. Again, there's a timeline of 23 through 27, right? So it's basically a 5-year timeline. And it's really based on 2 pillars and a foundation, right? And that support each other. What I'm trying to say is that if one fails, they all could fail, right? In some ways. So we're looking at I can't tell if it's your left or right, but it's the left on the screen and my screen is the organizational development priorities. That's sort of an internal facing, and I'll jump into some spaces around that. But that's basically the roadmap that Lexi has developed. It's internal facing. On the other pillar, the community impact priorities, that's looking at programmatic work. That's looking at external work. How do you work with the community? And then sort of those cross-cutting foundational priorities on the bottom I think it's best described as how we work, is community engagement. And I'll jump into all these different spaces in a little bit more detail. But that's the basic framework of the plan where it's at this moment, right? Next. So on the organizational development side, it's really about, it builds on the roadmap that I know you've seen that Lexi's shared with y'all before. So 3 main areas of work that in that space so far are supporting our people, rebuilding our systems, and developing an agency vision and priorities, right? So that internal focus, so we strengthen ourselves internally in order to better be able to do the work. Next. On the community impact side, again, this is around external facing programs. I put the mental and behavioral health space in there because that is a program space that we're going to be working, that we already know that we're going to be working on as the community health priority, right? Public health improvement plan priority from the community is mental and behavioral health. The other parts I put TBD is because we're going to use the community health profile, speaking with staff and partners and such to develop maybe 2 to 4 additional priorities as an agency that we're also going to be as part of our 5-year strategic plan going forward. And I'll jump into those a little bit more in upcoming slides. So on the bottom, we have like foundational priorities, right? And again, we're really talking about this is how we work. And this is how we work, I mean, across the internal organizational development work, as well as how we work on the community impact side, that external facing programs. And so these are things like community engagement and power sharing. These are things like learning and growth metrics, for example, policy, health and racial equity. These are spaces that they're going to be foundation support for those other projects or other programs that we're working this for, the 2 pillars. That makes sense. So they're going to be implemented across the agency, not just in these individual programs. Next. So on the programmatic priorities, what could some of those be? Again, the mental behavior health space is italicized, but we could include like climate action. It could include maternal child health, youth health, health in emergencies. Those are potential spaces, right? That throughout this fall and early into next year, we're going to be working using data, right? Data and evidence, looking at our capacity in our current work, what are our current strengths in these spaces, and an engagement process both with community and internally with staff on deciding what could be those additional programmatic priorities. And so the cross-cutting work is exactly the same, right? It's those 3 power spaces there of health and racial equity, community engagement and power sharing, and policy, right? And what does that mean? How do we embed those spaces, right, across all our work? Next. So I'm going to run through this very briefly, but we're looking at what is different. I think Morgan asked what is different from the last one, right? We're still using evidence-based or evidence-informed approaches, right? We're looking at services, social determinants of health across the continuum. We're engaging community, engaging staff. But one of the main differences is that for this next process is we're going to have a comprehensive across the agency embedding and metrics of all these spaces, including the foundational work as well, right? So if we're talking about community engagement, how are we as an agency doing that across all our programs, and how are we measuring that? So we're not just talking about it, we're actually measuring it and making sure that we're doing that. So staff should see themselves in some way or another in some place in this plan, right? Next. So part of this also, how are we going to do that, right? So we're engaging BCPH staff in the Board of Health, civil society organizations, and community voice, and partner community organizations as well. So this is a process of engagement. Next. And I don't expect you all to read every single detail on this map. I do would invite you all to take a look at this graphic when you have the time. So as you can see on the left, we have different trails, right? The organizational development, the program priorities, and how we work priorities. And basically, there's different dates and timelines on how we're going to get to an official launch of all this work early of 2024. We're looking at 2023 as that base planning period, detailed planning. So we have a full 4 years of implementation, which is much different than we did before, which took us a little bit more time to do that. So this is going to be updated on a monthly basis. We even have a little hiker to tell us where we're going on each one of these play spaces. So you'll see these, and you can ask questions about it and see where we're going on these spaces. Next. So as the next steps, again, we're looking at completing our community health assessment planning. Not the assessment itself, but planning with Omni, the detailed planning, meeting with key stakeholders and defining how we're going to reach community. We're working on the community health profile, and we're building out reporting and updating processes so people feel engaged, have the opportunity for input, and move things forward. And no less, I think that's it. Yep. So I ran through that really fast. There's lots of details, and I'm happy to answer questions now. And yeah, if anybody has any questions from the board or.
So the last strategic plan
Yeah.
did that come on the heels of a community health assessment?
Yes.
And community health profile, and those generally get updated every
5
5 years? Okay.
Yep.
All right, good.
So we're statutorily required to do that work.
Right, that's what I thought.
And so the last plan, we did have this space where we went out to community and asked them, and we did a whole narrowing process of, they want, here's the different priorities and make a final selection on that. But in this space, we're going to use mental behavioral health as sort of already chosen by the community. So we're going to use the community health assessment process to dive deeper into that mental behavioral health space.
Okay.
Connecting with partners and pulling out detailed plans, how we want to work going forward.
Okay.
Morgan?
Yeah, thanks, Kelly, for giving that overview. I mean, my question sort of follows on what you just talked about, because as I recall from the last strategic planning process, when I think affordable housing, ended up being sort of the top, and mental and behavioral health, and it was sort of a vote system with these community meetings. And so it makes sense to me that we would continue with mental and behavioral health. But in terms of looking at other issue areas that might become priorities, I heard you say it's going to be data driven. I mean, I'm just looking for a little more information about how the prioritization is going to happen and
Totally.
Yeah.
Yeah, so there's kind of two facets to this. One is, what are other additional priorities that we might want to pick up as an agency? And two, what are priority populations within the MBH space and those other priorities that we choose, right? And so part of that's going to be data driven, right? Quantitative data driven, right? Sort of what do the metrics say about our county? Who's impacted the most, et cetera, right? But I think we're also looking at diving down deeper into those spaces in the community health assessment process for mental and behavioral health in particular, and I'll get to the other priorities in a sec. And it's not just talking to, your local NGOs and things like that. it is talking with them, but it's going down deeper and connecting with the population, right? Connecting with people who often don't get a voice. And so in 2023, our goal is by the end of this year, or sooner, to have chosen those, those other additional agency priorities and that are backed up by using data. And then for 2023, we're going to use that year also as a data gathering year, detailed program planning, strategic planning around each one of those, and how to embed those programs and how to pull out metrics with those priorities across our agency. So I'll give you an example to help clarify that. So if we choose climate action, if climate action is chosen as a priority, an additional priority going forward, how is that work embedded in some of our current program work? How do we measure that? How do we pull that out? How do we work with staff in order to do that? So it's actually a true priority as an agency. It's not just some standalone siloed program on its own. It's actually embedded in most of the work that we're doing.
So Kelly, in that example you just gave, how does climate action get selected in the first place?
So we're gonna be done with the community health profile probably in November. And so at that point, then we're gonna pull together a process of engaging with staff and engaging with some community voice in order to make those selections.
Okay.
Right? So I don't know the exact process. We haven't put that in place yet, but that's how it's going to work. So by the end of the year or so, we have those selections made. So we jump into 2023 knowing that we have tasks ahead related to those spaces.
Got it. Okay, thanks. I mean, yeah, and that's great. And I just think it'll be important to maintain sort of transparency and being sure we're communicating really clearly, broadly with the community about opportunities whenever there are opportunities for folks to weigh in.
Absolutely.
Yeah, I think obviously mental health continues on as a priority in this plan, right? And a lot of things have changed since that last assessment was done. And you think about mental health and, okay, yes, we have COVID and all of the disruptions to our normal lives that occurred as a result of that. That contributes to our mental health. Obviously, we also had the existing problems before, which was addiction, opioids, that type of, and that leads to the behavioral and mental health sides of things. And then we had, of course, the traumatic event in Marshall Fire. And, it's like, how can you not think like, is next year or is this winter going to be the same? So it's all linked to mental health in the end. And so it'll be interesting to see when you talk to the community, if any of this kind of comes through, if you hear similar undertones.
Right. And on top of that, the county has mental health as one of their ARPA priorities. So they have a team working on a county roadmap in mental health. And we're part of that, right? So it's where does public health best fit? Where is our best lanes? Where do we need to put more effort into, maybe back out of some other things? We have really great mental behavior health work going on now, right? We have lots of great projects, and particularly in the community health program, but also across CEDAM and family health as well. How do we build a coordinated strategy? It's not taking those projects out and building another silo. It's coordinating that into a comprehensive program that allows us to really have a good take on what we're going forward in that space.
Well, sounds like an exciting process. Hopefully we can adhere to that schedule and no surprises come our way.
Lexi and I are taskmasters. We'll do that. So. Thanks, everyone.
All right. Thank you very much, Kelly. All right, item number 4, community health and youth voice.
Our second presentation tonight focuses on how our community health division has been engaging community voice, particularly of youth. We wanted to present this work tonight as an example of one of our approaches to community engagement and power sharing, in part because that's a direction that we've been exploring as a potential agency priority, as Kelly referenced in the previous presentation. Heather Crate, our Community Health Division Manager, will be presenting on behalf of a number of community health programs who use this approach, and which we also see in other divisions. We're also interested tonight in helping to center the board on the importance of this work to effectively advance health and racial equity and to seed some of the critical questions as we develop out this aspect of BCPH's work across the agency. Heather?
Thank you, Lexi. Good evening, board. I am excited to be here to share a little bit about our project as far as our approach. It's broader than a project really, but our approach to engaging youth voice in the work that we do. If you'd move forward, Jordan. So first I wanted to share with you all the community engagement continuum that is put out by the CDC. So as an agency, as many of you might be aware from previous discussions or director's reports, we're working toward increasing our level of community engagement and power sharing. So if you look at this continuum, on the left-hand side is the outreach level, sort of all the way to the right-hand side of shared leadership. We have many programs currently across the agency that engage with a community at a variety of levels on this continuum. And really, we're trying to work toward more of the right side of the model you see in front of you. So collaboration, shared leadership, really having community members and participants at the table and making the decisions. So in the Community Health Division, we have a long history of collaboration and shared leadership with our community. We continue to make additional strides in this area, and tonight I want to share with you about our efforts, particularly around shared leadership with youth. Next slide, please. So we have adopted this model. It started in 2016 of hiring young people. So we have colleagues between the ages of 15 and 20. They're hired through the same process as other county employees. They are paid hourly staff, so receive that same hourly livable wage that's identified by the commissioners. And it's really important for the youth that we serve to be able to provide this valuable input and perspective on all of our youth-facing services, our youth-serving projects. We currently have youth advisors employed in our Community Substance Abuse Prevention Program, Inspire Youth Connections Program, OASIS, Generations, and TEP, our Tobacco Education Prevention Partnership Program. And in addition to paid youth advisors, we also have youth who participate in many other leadership opportunities. They often do receive stipends and compensation, but maybe just need a commitment that's more once a week versus maybe the 4 to 6 hours that other advisors are putting in per week. And for us, this is really a true example of what it looks like to live out and practice those values of positive youth development. The wheel, sort of puzzle piece wheel on your screen, looks at the different components of the positive youth development approach. So making sure that we have practices and services that are inclusive of young people, that youth are truly partners at the table, that we have a collaborative approach, and that we're not just bringing in youth every once in a while, but we created this sustainable approach to engaging young people in an ongoing manner. And we did start in 2016 with just one young person from Boulder High, I believe, and they have now since gone on to college, and now we have several youth advisors. And we always approach, and have always, I think, approached our work with young people in a strengths-based approach, but now we engage youth employees based on their strengths, based on their interests, the type of work that they would like to engage in within our programs. Next slide, please. So this picture here is some of our youth advisors and youth advisor supervisors presenting about empowering youth voices. This was at the Shared Risk and Protective Factors Conference. So youth advisors over the past 5 years now, almost 6 years, have participated in a number of projects, led a number of projects. So they have led many presentations to adults on what it means to work with young people. They've supported research projects. We currently have some paid youth advisors supporting the projects of our To the Root program. They've done a lot of work around supporting mental health resources and have been instrumental in planning a Boulder County Mental Health Youth Summit that's coming up in October. They've created social media campaigns around vape prevention, around substance use prevention. Our TEP youth advisor is actually currently getting ready to launch, along with staff, a peer-to-peer youth vape cessation program that they've been working to build out, which is really cool. They run a youth events calendar. They help facilitate coalitions, and really present at public health conferences. I had the pleasure of presenting alongside some youth at a national conference that was held in Denver. So it's been a really great process, and they're involved in a variety of work. And I should have said it, at any point, if you have a question, feel free to jump in. Next slide, Jordan.
Heather, can I ask a
Yeah.
question?
Sure.
So was that the model that was used for the sugar sweetened beverages group in Lafayette or Louisville?
So it was a little bit different. That was more consultation and kind of short-term involvement with young people, but they did receive stipends. They did have shared decision-making,
Okay.
but it wasn't that same employed by the agency approach.
Okay, thank you.
Yep, and that was in our environmental health. So as we've brought young people into the agency as employees, you can imagine that we've learned some lessons about how our agency is or isn't set up for having youth employees, what it's like to work with youth, and what types of impacts young people can have when they're at the table. So some of the pieces we've learned about with hiring and onboarding, this process can be cumbersome, I think, not only for young people, but generally community partners who maybe aren't as community members who aren't as engaged in government processes. One way we combated some of that is we did offer informational sessions via Zoom in the evening to talk about the application. One piece that we've discovered, and we've created some creative workarounds, is we're unable to hire undocumented youth. So we've been able to do some gift cards and other pieces, but that's a voice that we know we haven't been able to bring in. Another learning is just that we have to be ready to work with youth. We have to shift some of the times that we're holding our meetings. We have to shift some of our approaches. We have to be trained, working and engaging with youth. And I think with any community member, you can't just bring them into your already standing meeting with your culture and your team approach and expect to plop them in and that there's comfort and ease in that. So you really have to do some intentional work about what it means to share their voice and showing them that you're really looking for some shared power in this space, and that they're not just sort of this token young person or token community member who's sitting there. So we've done a lot of positive youth development training in our division. We've adjusted times of meetings, more evening meetings. And then the biggest piece we learned in that area was just making sure we have clear expectations and understand what the young people want to get and what they hope to affect as far as change. And that's the community impact piece. I should have mentioned, we've had young people who've been able to speak at school board meetings, talk about how things like vaping or substance use or pregnancy have impacted their lives or their friends or their community, and to really advocate for truly the needs of their community versus us as public health professionals coming in and letting them know what their needs are. Hearing directly from them has had a major impact in our community. Usually sorry, I got an echo. Usually the approach with young people is just them truly having a seat at the table. So through our hiring of staff, we always have young people as part of the committees. As far as decision making, if it's a youth-based process or project, youth voice carries a lot of weight in those spaces. And this is a picture from a pumpkin carving evening that they had. Next slide. This is the final slide. So as far as what this means, why am I presenting to the board this evening about this, other than to tell you about this really great thing that we're doing? We really want to build additional opportunities for youth leadership within our agency, within our decision-making, even maybe at the board level at some point, and thinking additionally beyond youth, community members more broadly. What does it look like to employ and hire people in the community doing the work beyond just that partnering layer? We are working toward having youth advisors in every program. We at least have youth boards and youth decision makers. They're just not all quite advisors at this point. We have been sharing our approach with public health partners. So like I shared, the young people had presented at Shared Risk and Protective Factors. We have some young folks presenting with the OASIS program at Public Health in the Rockies to talk about this approach. There are several, well, I don't know about several, there are some other public health departments who have paid youth advisors. And there's some really great modeling of what this looks like from some guidance that Colorado Department of Public Health put together a few years ago, the Colorado 9 to 25 project. I don't know if anyone remembers that, but Allison Bailey from our team was really heavily involved. And then really thinking about how do we explore this as a model more broadly for community engagement as an agency. So not just youth, but other populations or other community members that we want to make sure we engage. So that's all that I have this evening. I don't know if there's any additional questions. Morgan?
Yeah, thanks, Heather, for walking us through this. This is really cool that you and public health have done so much to try to engage youth and really involve them in all the different levels. And I think naturally it sort of brings up questions about the Board of Health and youth perspective. And I don't know actually what the requirements are. You know, I know that there's a bunch in statute around how the commissioners appoint boards of health, but it might be sort of interesting at some point to explore what it might look like to have a youth member that might not have the same voting opportunities because, again, of the statute limits. I don't know. I don't know if there's an age requirement. I know there are other requirements about for Board of Health members, but it just might be interesting to think about that since you're doing so much to incorporate youth into other places around the agency.
Yeah, definitely. And it's something that we, as a division, we've talked about, you know, just thinking through what would that look like even in an advisory role or a consultant type role around some decisions, even if they don't have a voting position.
Well, I appreciated learning, seeing that chart on outreach, because, you know, trained as a scientist, you know, we don't get a lot of that. Oh, well, outreach is, but you just go out and you talk and you take questions and you give answers. It's like, what I'm thinking of outreach is all the way on the left spectrum, and then, you know, trying to move to that collaboration and phase and beyond. Obviously gives me some homework to do for my own work, but I really appreciated seeing that, so thank you.
Yeah, you're welcome. And I think that continuum helps people see that we are doing community engagement, even with outreach. Some folks say, well, we don't do community engagement, some of the programs or some of the maybe more regulatory pieces. And I think really in public health, we all do it. It's just maybe at a different level.
One of the exercises we did a number of months ago when we were beginning to talk about community engagement and power sharing was that Heather led a process of mapping where on the spectrum various programs across the agency really sit in relation to this spectrum. And a conversation about and what do you think is the place that you would want to get to for this particular program? Because it may be different for different situations. But that was a really eye-opening exercise for us because it really highlighted how much work we have in this space generally, not specifically in relation to youth voice, but broadly related to community engagement. And I think it also really helped staff to, put some words to some ideas that they had and become a little bit more specific about what their thinking was.
And if I could just add really quickly to a little bit tangentially to our division, but we also have one of our TEP staff currently working in CDM around teen and young adult work as far as developing immunization campaigns. So some paid youth employees and youth advisors in that setting, a little more term limited, but one of our community health staff is helping the CDM folks with that piece too. And that's been really great.
Any other questions? Okay, thank you, Heather. Appreciate it.
Thank you all.
Item 5, Family Connects and the 4th trimester nurse home visit.
Our fourth presentation tonight is about the fourth trimester. It is the culmination of several years of work at BCPH and with local hospitals that was started under Jeff Zayak's leadership. And he has continued to support the planning in this space. The implementation of the Family Connects model is useful both for its potential community impact and also for our agency. Daphne McCabe will talk mostly about the community impact tonight, but I want to let you also know that this initiative has helped knit together our BCPH home visitation programs specifically, and also create a more integrated approach to how we support families more broadly in Boulder County, such as providing an entry point to support our emerging Healthy Homes program, with more to come. 3 takeaways we hope you gain from tonight's presentation are that Family Connects provides a new standard of care. Instead of waiting 6 weeks after birth for an office visit, every new mom will be offered a 3-week at-home visit to assess a wide variety of needs and support, and provide support to ensure a strong start for babies, as well as 2 more Family Connects visits and referral to other home visitation programs as needed. All of the services are free to families, from a focus on developing healthy baby brains all the way to connection to social services. Family Connects takes us from our current reach of around 15% of birthing moms to 100% within 18 months or so. Number 2, we have 3 years of bridge funding awarded by the Boulder Office of County Commissioners, which will carry the program as we work with state partners to develop sustainable funding sources. The state is particularly interested in this model given the documented return on investment communities realize by investing in early childhood. And number 3, this initiative aligns with the strategic direction we are moving to more broadly in public health, shifting towards primary prevention, community engagement and power sharing, and health and racial equity. Daphne McCabe, our Family Health Division Manager, is here to present tonight. And Daphne, I'm happy to turn it over to you.
Great. Thank you so much for having me, and thank you for that overview, Lexi. We are thrilled to tell you more about the program. So next slide. So as Lexi alluded, Family Connects basically transforms the current system and increases the level of care by empowering parents and connecting them to resources at the beginning of their child's life. So the nurse connects with the family and identifies the needs in the comfort of their home. And the nurse connects the family to community resources that the family might need or want. In the other similar communities that this has launched, approximately 95% of all families need some form of referral. So, and then the parent is able to get support in bonding with the infant, including lactation consulting. So that's the model in a nutshell. Next slide. And what's important is that locally, we've talked about family on that community engagement slide that Heather showed. We've talked about wanting the community to drive the programming that we do. Well, as Lexi alluded to, about 5 years ago, there was a survey done, and 80% of Boulder County families with young children would participate in a home visit. So it's a need that our community has requested. And right now we're currently reaching less than 15%. So we're excited about this opportunity. Next slide. So in Boulder County, well, across the US, the birth of a child, the household cost of living jumps by $18 an hour instantly with the addition of the infant. And this was based on some economic research done by Colorado Evaluation Lab. If you want to go to the first, press a button, there you go. When the person's pregnant, they can get by without any government programs at approximately $19 an hour. But as soon as that baby's born, it jumps to $37 an hour if you wanted to live independently as a household of two. So that includes childcare, that includes, which is very expensive. It includes extra rent, et cetera, et cetera. So that gap of $18 an hour, do the next slide, next, can really cause a lot of stress with a family and with a household. And so, and next slide. What we wanted to show you was how Family Connects empowers parents to reach out for the resources they need to bridge that gap. And those resources might include WIC, which is Women, Infants, Children, might include SNAP, might include reaching out to family resource centers, and might include childcare supports like CCAP, et cetera. So you want to give it a try, or shall I try?
Yeah, so Teams Grace, everyone.
When you do the share, if you press the button, if you go back, you press the share volume button from the beginning.
Yes, when I shared my screen.
Okay, let me see if I can do it.
Try.
Okay, include computer sound is at the very top button on the right. You did that? Okay. You want me to try?
Yeah. I wonder if it's because it's trying to pull off my computer
It could be.
and my computer is muted. That way there's no.
Could
I can mute this.
From another.
Could you hear that?
We couldn't hear the sound, but we could see all of the images. So I think we got the gist of what was going on. We just couldn't hear the words.
Okay, well,
We will send the video separately.
Sorry.
oh, no, that's okay. It's not your fault.
No. We're working through all the new technology issues, so.
That's an example of a nurse home visit in another state that's already launched, the state of Texas. So I'm so sorry because this means that you all won't hear about 9 minutes of video from staff, right? Because-
Well, and just to give you the gist of the video, the parents were really talking about the peace of mind that it provided, about the guidance that they got in those early days that just gave them a lot more confidence about being new parents and the stress that comes with that was provided by the program. Let's try running it from your, the second one from your computer and see if that.
Just real quick, maybe give us, so yeah, I'll do that real quick and see. I'm presenting right now and,
See, I think you're gonna need this.
whoops. Sorry?
I think you'll need this in order for the TV to connect. I tried
Well,
that
maybe
earlier
that-
today and it didn't work.
No, I'm just having her dial in as a participant. Will that work?
Yeah, but I mean, it's gonna be the same thing with mine, to where it's reliant on the volume of my computer to play. So this should play through the TVs, but it wasn't working earlier, so I don't know.
Can I try just for grins without that and see what
Yeah,
happens? Okay. Let's see. Turn off your volume on all levels and.
Good evening, Board of Health. My name is Felicia.
I heard it for a second, but it froze.
That's good.
Okay,
Okay.
so this will work. So let's
Okay.
go on with the.
Yeah, we'll go
PowerPoint and
on
we'll
with
come
the,
back.
okay, we'll come back. I'm worried about. Okay, so I'm gonna stop presenting. Or can you make yourself presenter to go back to the PowerPoint? I'm gonna keep this the way it is right now. Okay, so then you can just advance. Okay, so basically the way the Family Connects visit works, it's a new standard of care where right now, when it comes to the maternal care leading up to the birth, there's prenatal visits every 4 weeks. And then as the birth gets closer, the due date gets closer, it's every 2 weeks and then every week. And then 24/7 care in the hospital for the 1 to 3 days during birth. And then at this point, it's 6 weeks for the postpartum visit that's focused on the mom. And so Family Connects and you can press a button, Jordan, thanks, fills the gap with a 3-week visit where they can connect with the mom and check on the mom's health and well-being. Okay, next. By doing this and providing the visit universally, regardless of income, in other similar communities, they've seen a decrease in child protective services investigations of 44%, a decrease in maternal postpartum depressions and anxiety of 30%, and an increase in community connections of 13%. And this is because they really are offering and empowering the parents to reach out for help earlier in the life of the child. And it consequently addresses birth equity because some of these areas disproportionately affect BIPOC community members. And so we found that it helps equalize experiences with BIPOC communities by increasing resource access. Next slide. So how can Family Connect support other public health programs and priorities? Well, while that home visit's happening, and it's an evidence-based model, and it's been deployed in 8 other states. It's in general, the model, when followed to fidelity, reduces emergency room visits, which is of course really important for public health to make sure emergency rooms aren't overwhelmed by anything. Reduces maternal depression. There's an increase in screening and referral for substance abuse. There's an increase in the healthy homes because you can do lead testing while the nurse is there if families want it. And again, this is a voluntary program. People can choose whether or not to accept the home visit. Connections to smoking and vaping cessation programs are also offered in the visit. And the nurse helps educate families on childhood vaccines, often giving them good information that helps increase the vaccine rates locally. The well child follow-up visits are often scheduled in the nurse home visit. And so you see an uptick in that. You also see an uptick in having a health home for both the mom and the baby. You see increased access to healthy food through referrals of WIC and SNAP, and you see increased access to childcare resources. So these are the types of things that we care about already as a public health program. This just becomes an opportunity for that parent to be engaged in seeking their own help in these areas, because then they learn about them and they get to know about them. And even if they don't seek help in that particular visit, over the course of the next 3 years, they often will return to the resources that they learned about and seek them when they need them. Next. So some of you may be familiar with this, what we call the rainbow spreadsheet of home visiting programs that currently exist in the program, in our community in Boulder County. We have Child First on the far left, which really focuses on mental and behavioral health and is a very longitudinal, high intensity program in the home. And that's on the far left, the most intense. And then as you go left to right, you go to the least frequent in terms of visiting and the least intense in the home. So again, Child First, then you've got Community Infant Program, which is with mental health partners, Children with Special Needs, which is public health, Nurse Family Partnership, public health, Genesis is public health, Early Head Start is national program, and Parents as Teachers is as well. So all of those exist today and serve approximately 12% of the population. So that's 88% of the population that's not being served by anything in this continuum. The Family Connects service is up to 3 home visits. Most of them are just 1 home visit. And it's really for the postpartum period with a nurse, a trained nurse, who checks on mental health, physical health, and well-being of the family. Next. So now we're going to share with you the what the team is excited about, and we hope this will make it really real for you. Go.
So you need to share.
Oops. Okay.
I think it's better since you're under a mic as well. So.
Okay. Share this. Let's see. Start from here.
You may need to unshare. Here we go.
My name is Felicia Kane. I also go by Felice. I am the
Let me stop for a quick second and just see if somebody can give me a thumbs up on whether or not they can hear it.
Can anyone dialing in hear that? Hear the
Natasha?
We can
You
hear
can? Okay, great.
Family Health Nurse Services Coordinator and the new nurse supervisor for Family Connects. I am joined by the Boulder County Family Connects team. We are at Boulder Community Health Foothills Hospital for our first kickoff meeting. And one thing that I'm really excited about for Family Connects is the opportunity to integrate and elevate family voice to be a model for the rest of Colorado. So I'll pass it off to Jeff.
Hi, everyone. I'm Jeff Zayak. I'm the strategic advisor working part-time for Boulder County Public Health to support the launch of Family Connects. So during the time that I was executive director for Boulder County Public Health, I witnessed multiple times the gap in need for primary prevention in early childhood. This was clearly highlighted even more during 2017 when we were working in partnership with Early Childhood Council of Boulder County to complete an early childhood mental health assessment. And thanks to you, Heather Matthews, for helping lead that work. That was critical. And as we all know, the most important time in a child's life is that first 5 years. Significant impact to life, lots of brain development. That's when the vast majority of brain development occurs. And this is where Family Connects for me really comes in key. It's an evidence-based program. It's universal. It's available to all new parents. There's no eligibility requirements. There's no cost to parents. One of the things I love about Family Connects is that it requires heavy integration of family voice into the program, and we all know how much that's needed. And that ends up reducing stigma and closing the equity gap for new parents that's existed in our county for some time. And I see this as now it's the opportunity to launch this program statewide. We have really good support from the governor's office, multiple state departments. We have Illuminate as a statewide intermediary to administer the program. We have 2 counties, including Boulder, launching as pilots this fall, and then 2 other counties are following with a launch in early 2023. So, and all 5 of our hospitals are fully engaged and supportive of this work. So this is the time to get it done. I've wanted to see this happen for some time. It's been a passion. It's why I've come back and helped support this after my retirement. And I want to personally thank you, Boulder County and Boulder County Public Health, for all your support. And I'm going to stop there and I'm going to pass it over to Kate. Kate.
Hi, my name is Jade Ricard, and I'm a nurse with the Family Connects program. And there's a lot of things that I'm excited about, but one of the main things is really supporting and encouraging that infant and parent relationship and telling parents how important that connection is, and supporting the mom's mental health, but also, I don't know, just making sure that parents don't miss out on that first year. A lot of times it's easy to think, well, the baby's just sleeping there, to kind of miss out when there is so much brain development happening, when a child that has a parent that's lovingly engaged, that is responding to the baby's needs, that is reading and singing to the baby, that it really, truly does make a difference. So that's one thing that I'm excited about.
Hi, I'm Heather Matthews, and I'm a consultant working on the project, supporting the Boulder County team to stand up Family Connects in Boulder County. And what I'm excited about with Family Connects is really, number one, seeing this moment come to fruition after watching the community agree that universal home visitation was really the direction that we needed to go to best support families. So that's incredible. The other piece is just really empowering communities to support families in new and meaningful ways, and recognizing that we just need a new standard of care in how we support families at this really critical moment and bringing a new baby home. So there's a lot more that I'm excited about, but I think this is an amazing team, and they have a lot to share. So I'm going to stop there. What you did now.
Hi, I'm Danielle Zaitzu, and I'm a registered nurse at Boulder Community Health. I'm also supervisor of the Parent Education and Rehabilitation Department, and I'm thrilled to be working with the county on this project. It's been a dream of mine to get into the home, to be able to provide universal care to all of our families. Bringing nurses in the home can really impact how baby's growth and development takes place, as well as maternal health and well-being and mental health. So I think just being able to do that regardless of socioeconomic status, or regardless of insurance, to have that ability to see all families in our area is something that is long overdue. And I am just, again, excited to be working with the county and having this great opportunity. So thank you. Hi, my name is Natasha Stewart, and I am a registered nurse for Boulder County Public Health's Children with Special Needs program. I am super excited to become a Family Connects nurse. Being able to visit all families is so critical. The postpartum period is a very vulnerable time for parents and babies, and doing a home visit, you just get to see so much in terms of what's happening with mom and baby, the family dynamics, what resources they might need, assessing mental health for families as well is so crucial. So I am just so excited to get into the homes and visit everybody. Thank you. Hi, I'm Tina Cartelli.
Also a registered nurse with Boulder Community Health, and super excited to be a part of Family Connects and Boulder County. And the thing I'm most excited about is we all know that having a baby is super exciting. It's not rainbows and unicorns. So a few weeks down the road, things come up, parents get stressed. A lot of things can happen in those first few weeks. And I'm so excited that we'll be able to go in and to support these families and provide those resources they may need. Thank you.
Hi there, my name is Sutia Berman. I'm also a registered nurse that works here at Boulder Community Hospital. I'm also a lactation specialist. So I'm really excited to join this group. Being in the home, as one of my other colleagues had mentioned, it's a new standard of care. And we've in the past had, a person give birth to a baby, and then it's 6 weeks later that we're actually checking in with them. So this is an opportunity for nurses to go and see them in their house, do a full assessment of mom and baby, just to see if we can help before they get to their 6-week visit. So it's kind of bridging that gap of when they're going to get care already, but kind of going into the home and really assessing how are they doing in real life in their own home with this new baby. So it's providing support, resources, anything that we would be able to do to help that transition of having a new baby in the home, helping that family through that transition. It's an honor to have. Thank you. My name is Megan Hale. I'm a licensed clinical social worker, and I am the bilingual infant and early childhood mental health consultant to the team. I'm thrilled that this program exists for many reasons, but one of the reasons is that this is a wonderful opportunity to normalize perinatal mental health care, including assessment, normalizing that this exists for both infants and young children, as well as primary caregivers and parents in our county. And I'm also really excited about this program because, and my role in it, because there's an opportunity to support the nurses on the team who are going into homes and doing difficult work. And to me, it's really natural and normal to need support in this work. So thank you.
Hi, my name is Aurora Ramirez, and I'm the program assistant for the Children with Special Needs program, and I will be the program support for Family Connects. And I am very excited to see how this will impact the community and support not only our families, but also support our nurses and our team. So I am very grateful to be here. Thank you.
Thank you. Let's stop sharing here. And so those are our nurses and our family, our folks will be doing the program. I'm going to come back to you. Yep. Okay, great. How do I stop sharing? You think I've done this before? Should I maybe leave?
Yeah, that works.
Yeah. There we go.
I'll have the video, all the sound figured out before next.
Okay, great, no problem. And then just a couple more slides and then we'll open up to Q&A. All we want to do here was just emphasize again the level of statewide support that we have for this program. We are the pilot program. We're the lead county across the state. The state does hope to roll this out statewide because of the positive effects overall. So we've got all of these Office of Early Childhood, Eliminate Colorado, Colorado Health Institute, Colorado Partnership for Thriving Families, the Evaluation Lab, and Denver County and Jefferson County, as well as Eagle County. So it's a pretty large infrastructure at the planning level with the local hospitals. We're engaged in conversations with, we're engaged with the launch and the pilot launch with Boulder Community Health with their nurses being trained along with our nurses. And then we're in conversations with UC Health for a launch in early 2023. And then Centura and Intermountain we're also engaging with. So next slide. So our roadmap is to launch to Fidelity with the evidence-based model. and kick off the implementation team this fall with inclusion and amplification of family voice. We have a whole plan and infrastructure similar to Heather's, where we're paying Family Voice to participate and reaching out to many community members and agencies to help guide this. We'll learn a lot this fall, and then that'll help us inform our Longs Peak training and our continual process improvement. In 2023, we'll have gather the full community advisory board and have the kickoff with all community members. We'll have data systems development, which will also be informed by the community members. Centura planning and family voice and power sharing equity work will happen in 2023. And next. This is really the final slide. Really, we just wanted to emphasize how we've had to set the bones up for this, but it's now time to add all the meat and muscles, and that's the community partners and the family voice. And so we have the service providers in the community. We have community voice coming together through the community advisory board, but also in other spaces. We'll have family voice through both the community advisory board and through engagement with them throughout. And this is a unique model where through the fidelity model, the family is called 4 weeks after the service to see how did they like the service, did it work for them, were they connected with resources. So there's a closed loop referral, which is another piece of why it's a powerful model, because if anybody's starting to fall through the cracks, they don't anymore. So anyway, and that's our resource partner. So thank you very much for your time. Really appreciate it. And I'll open up to questions if you want to move it to the next slide.
Andrew.
I was just wondering, what's the mechanism for referring patients to the program?
It will be through the hospital at birth. So they will be offered by the nurses at the hospitals are trained in how to offer the program. And when it's offered, there's some very family-friendly resources that include the picture of the nurse who do the home visit. So the visit is scheduled ideally scheduled before the family leaves the hospital. If it's not scheduled at that point, it's they opt in, and again, they have to sign a release of information. This is a total opt-in model. But they sign the release of information, and then the nurse that they've been kind of introduced to virtually reaches out to them to schedule the appointment. And yeah.
So this isn't something, I work at Clinica.
Oh yeah.
So this isn't something we could initiate with our case managers ahead of time?
Actually, it can be, and that Siobhan is on our team with that rainbow spreadsheet, and she's been helping us think through some of this. So it could be that we can get there, and in an ideal world, once this is fully launched, absolutely that happens. Then in communities where it's fully launched, the OBGYNs start to talk up the visit from the moment they first meet the family. So, but right now we're just at like the first bite of the apple. So we're not integrated throughout the whole life cycle of the pregnancy yet, but we will be eventually over time with family voice. Again, we want to make sure that we're outreaching to them in the way they want to be outreached to, et cetera.
So, well, if Siobhan's on the team, I think it will happen. I have no doubt.
Yay.
But so right now it hasn't gotten off. It's not done yet, so we couldn't start.
No, the first visits won't happen until mid-October. We have to get approval from the feds for one of our grants for the implementation plan that we've submitted. That's all just paperwork stuff, but there's just some boxes that have to be checked off before we do our first home visit. But we're all trained up and ready to go mid-October. And again, in the beginning, it'll initiate at the hospital, but Siobhan, from the minute that we say go, we'll start to promote it with any prenatal families that you all have.
I'm sorry, holding the floor. How is it different than the Nurse Family Partnership and SIP?
Such a great question. Nurse Family Partnership and SIP are both 2-year programs. This is a 1-visit program.
Okay.
If families are already connected with SIP and Nurse Family Partnership, during the pilot phase, they will not be offered Family Connects because it's a duplicative. So it's really for that 88% of families who aren't already at SIP or NFP.
I think that's great. I mean, I can think of a patient actually from today who doesn't qualify because of income for either of those programs, but would really benefit from both of them. So
And that's fantastic. Thanks for saying that, because especially if that person happens to have any mental health issues at all, another part of the model is we have a grant for a mental health navigator. So that nurse is going to make that one home visit, but then that nurse can, or up to 3, that nurse can then tapping into Megan Hale, our mental health consultant who you heard from earlier, and the mental health navigation resources we have in place, they'll get more support than just that 1 to 3 visit.
Okay, that'd be great. Yeah, I think it's more, just it's not probably a clinical mental health issue. It's just sort of overwhelm, and
Sure.
Just having a newborn is a like event, and I think a lot of people are wildly unprepared.
And that's another reason why they do the visit at between 3 and 12 weeks, is because that's about when the natural supports evaporate. That's about when the home cooked meals stop coming and the in-laws go away or whatever, and so then it's the parents and the infant.
Reality
Sets in about 3 weeks. If they do it before then, the issues don't surface quite yet. So that's why.
That's great.
Thanks for that validation. I promise she wasn't a plant.
Awesome.
Morgan.
Yeah, thanks, Daphne and team, and great work on getting this off the ground, because I know it has been a long time coming. So it's awesome to see it moving forward. And I had a couple questions. One is, when a referral is made to other services, how is that information relayed back to the mother's primary care provider and or the child's pediatrician? Is that all coordinated in terms of sharing referrals?
Assuming that the family has signed off that it can be shared, then yes. And it's right now we're tapping into Creo, and we're also working on, there's a FCI, a Family Connects International database, where you track all those referrals. And then not only do you track the referral, but you also track 4 weeks later whether or not the connection was made and whether or not the service was provided. And those details are all given back into the Creo. That's what we're working on. So we do have an IT systems build plan in place that we're going to submit for in early 2023 in conjunction with Boulder County Connects and all the county systems. But for right now, we're doing that process that I just described.
Yeah, right. And good luck. And I wish you luck with that, because I feel like it's always so much more complex than they tell you it's going to be. But that's great that you guys are thinking about it and working on it. And then my other question is around, it sounds like there's nurses that are employed by the hospital, nurses that are employed by the county. I'm just thinking about how is this being paid for? And if a family has private insurance, is insurance paying for it? There seems to be a financial incentive for insurance to be paying for it, but just thinking about Medicaid, are they paying for it?
Another great question. Right now, it's a blending and braiding of a lot of funding, but the large majority of what's going to sustain us over the next 3 years is a very generous ARPA grant from the commissioners to support the launch. And all of those state agencies that you saw in the pink are all working on the fiscal sustainability plan. It is absolutely imperative that no family is ever charged for the home visit. That's a big piece of it. And I use as an analogy hospice. When a family goes into hospice at that transition time, they're not charged. It's a similar, it's got to be a similar sense of goodwill, standard of care, health investment by our society to make it universal, and just know that this is a very unique transition. So those are the things we're working on. Other communities, yes, you can blend Medicaid, you can, and we're working on that. We've got Gretchen Hammer at the Medicaid billing level working on it. And there's other, probably 5 other ways. That's probably an entire other session, so I won't keep going into it, but I'm happy to either take it offline or forward you all of the work that's been done on that, because it's a heavy lift.
Yeah, thank you. No need to forward it. I'm just interested to see whether or not, you can get ultimately insurance to pay for it, public and private insurance, just because, again, the benefit to them saving costs and down.
That's kind of what we have to prove over the next few years is show them the cost savings, and show them the increase in health metrics. And that's how, you're absolutely right. That's how you get that investment to happen. The puzzle is when you've got the high deductible insurance. So anyway, it's a whole nother puzzle. Yep.
Okay, awesome. Thank you.
Great questions. Well, thank you for your time. I know we need to move along.
Thanks, Daphne.
Thank you, Daphne. Okay, we are on to item 6, director's report. We didn't have any time to discuss it in August, but I really do like the new format. You know, I like the conversational aspect of it instead of the bulleted aspect of it. So good job there, leadership team. I did have just kind of more information, I guess, on the opioid settlement.
Yes.
And so $1 million per year for the 18 years. Is that what we're hearing?
I don't remember the exact numbers, and they will definitely change because more settlements continue to come in.
Okay.
The current strategy right now is we're working on seating the Regional Governance Council, which will be seated in the next couple of weeks to review some early kind of shovel-ready, shorter-term initiatives that are deemed to make an important impact. That will come before the Regional Governance Group for approval or comment. And then the team will start moving into a process of longer-term strategic planning to bring kind of more vetted multi-year investments forward to the Regional Governance Council.
Okay. And that was the one, was that the result of the one that was announced like a week or two ago?
No, that amount was prior, yeah, dating back to even maybe last year, once that first bolus of money came through and states started to be able to see that there was actually going to be some money coming. They began to move into state and regional structures for how to disperse the funding.
Okay. Well, I don't think exciting is the right term, but progress, I guess, for trying to alleviate the issue going forward.
And it does signal kind of the complexity of the MBH space right now, because there are so many different funding streams that are coming to state governments, county governments, ranging from, services to treatment, primary prevention, harm reduction, all kinds of different spaces. And part of our challenge right now is really just staying coordinated enough as a county, and also making sure we're not stepping on each other's toes as we move forward with the work. I do have a couple of things I'd like to raise up for folks, if that's okay, in relation to the director's report. First of all, we do have a few kudos. The Pinnacle Awards were recently awarded by Boulder County Public Health, and these awards recognize exemplary programs related to the values of Boulder County. And BCPH had several winning nominees associated with 3 county values. The BCPH Long-Term Care Facility Team and Epidemiology Infection Prevention Leads were recognized in the category of resilience. The COVID-19 Food Delivery Program in the area of innovation, and the Boco Beans Program in the area of sustainability. Also wanted to note that we had 3 staff members who were recognized in the Circle of Honor, which recognizes staff who've worked for Boulder County for 18 years or more. Those were Lane Drager, Carol McInnes, and Patty Huerta Garcia. 4, excuse me. And also Natalie Villalobos Mendez, and they each get $2,000. So that feels like an awesome retention strategy if we can get a few more people to that. It's a long-term run, right? It's visioning. Third, wanted to mention that Heather Crate has been accepted into the DELF program, which stands for Diverse Executives Leading in Public Health. It's a program in partnership with ASTO and the Satcher Health Leadership Institute at Morehouse School of Medicine with funding from CDC. Congratulations to Heather. And finally, just to mention that a couple of weeks ago, our Works program had the honor of hosting the Canadian Minister for Mental Health and Addiction, who came to visit the program as a model program, and really had some wonderful conversations with the program and also with our community partners, the DA's office, our partners in the city of Longmont, mental health partners, et cetera. And we just really appreciated that chance to kind of show off, you know, a really innovative program offered by BCPH for over a long period of time. Next slide. Yeah, and this really just relates to what Greg mentioned. I'm sure you noticed we're piloting some shifts in relation to the director's report. We really have looking at a section that kind of helps the board to prepare and get centered in their thinking in relation to the agenda items for the next meeting. Also, keeping you all up to date on kind of some of the internal conversations that we're having so you can see where our thinking is going. And then our division sections will still be included. They may be a little bit shortened and kind of raising the conversation up a little less tactical activities and a little bit more kind of a holistic approach to what's happening in the programs. Also thinking in relation to the Board of Health meetings, having fewer presentations with a more strategic aim. We did an example of that tonight. Including more time for discussion, and making sure that if something is really just about updates and we don't expect it to have many questions, that would really be either in the director's report or you would receive those through a regular listserv that we're circulating, such as our COVID updates. So I'm very happy to get other impressions of how that director's report felt or how the agenda this evening felt. We really want to make these resources something that meet the needs of the Board of Health. So appreciate any guidance on that.
I like this format. I appreciate it. And I thought the meeting went well.
Great, thank you.
Yeah, agreed, Lexi. Thanks. I appreciate the tightening of the meeting agenda and the director's report flow. And so this is great. Thank you. And thanks to staff for making it happen.
Yeah, and just serious kudos to Jordan and to the staff for pivoting in this space quickly. Jordan's also working really hard on getting that package down in terms of pages, so it's a little bit easier to wade through for you all. So thank you for that feedback, and staff thanks you too. And I think staff. Hey, great, and that's it for the director's report. Unless others have other board members have any questions about what was contained.
Okay. Item 7, old and new business. Joe, you're still on the phone, so I just wanted to just kind of let people know that Colorado Environmental Health Association annual conference begins tomorrow. Most people will be there Wednesday through Friday half day in Crested Butte. Pretty high registration numbers, probably not surprising. A lot of people will make that long drive because it's a pretty beautiful drive. I'll be there. And I know that several Boulder County Public Health staff will be there doing a panel presentation on Marshall Fire, also doing some presentations for sustainability track. So one of the things that I just wanted you guys to know was that I did nominate the team for one of the CHA awards. I think it was the Innovation Award. It might be a different one, but I shared that with Joe. I have no idea if we'll win or not, but really proud of the work. And it was like 25 people that we listed in that nomination. So good work, Joe and team. Good luck. Trying to unmute, Joe.
Yeah, I was trying to.
There you
Thank
go.
you,
We got
Greg.
you.
I really appreciate that nomination. I know the team, really worked hard for the community on that event. So I know they're really going to be appreciative if they actually get the award, and I think they probably will. But I just want to thank you for submitting that. It's much appreciated.
You're welcome. Any other items? Seeing none, we are adjourned. It is 7:13. See you next month, everybody.
Thank you.
Guess I'll see them this month.